Welcome to the EAU podcast series, Present and Future of Diagnostics in Prostate Cancer. In this second episode, we are joined by Dr. Tamás Fazekas and Professor Monique Roobol. Together, they will discuss challenges and opportunities in screening for prostate cancer. Join us as we embark on this informative journey.
So welcome everyone at today's podcast on the challenges and opportunities in screening for prostate cancer. I'm Tamás Fazekas, a urologist at the Department of Urology at the Semmelweis University from Budapest, Hungary. And it's my great honor to welcome here today one of the key opinion leaders, and I can say a real guru in prostate cancer research and screening in particular, Professor Monique Roobol from Rotterdam.
Thank you, Tamás. Thank you for this very kind introduction. My name is Monique Roobol. I work as an epidemiologist at the Erasmus University in Rotterdam, the Netherlands. And my main occupation is obviously prostate cancer and prostate cancer screening.
Professor Roobol, the debate about prostate cancer screening has been ongoing for decades now, and it has always been a really hot topic. But however, I can say that in the recent years, with the advent of the new generation of clinical trials, integrating MRI and novel biomarkers in the screening pathways has become even more relevant than ever. But to start with, can you sum up for us in a few words, where did prostate cancer screening started? What have we learned from the first trials, and how did we arrive upon the contemporary screening pathways which are being tested in contemporary trials?
Thank you. Yes, indeed, it is a very exciting time at the moment, and this all started in the early 90s when the large randomized trials on prostate cancer screening were started, like PLCO and ERSPC, and somewhat later Göteborg 1 and the CAP trial from the UK. And what we learned from these trials, which were a more or less a one-size-fits-all approach with PSA almost always, when elevated, immediately followed by systematic prostate biopsies, is that one, we could reduce prostate cancer mortality. It took some time to convince everyone, especially in the US, but I think we now all agree that on the basis of these trials, these early trials, we can safely conclude that with prostate cancer screening, we reduce metastatic disease up to 50% actually, and prostate cancer mortality. And there the range is, if we look at the CAP trial with a one-time screening, it's now approximately 4%. And the largest randomized trials like ERSPC, Göteborg 1, it is now around 20 to 25%. So that is the first thing we learned, a positive message. But on the other hand, we also learned that the way we did it in those trials, those early trials, was not the way to continue because we created a lot of overdiagnosis. And we know from the ERSPC data, for instance, that approximately in the age range 50 to 64 years, 70% of the cancers were low risk. And that is something, obviously, we had to work on, because this is not what we want, because especially in the beginning, in the early 90s and early 2000s, all these low-risk cancers were actually actively treated. So good news and work for further developments, and that's what we did in the years after that.
Thank you very much. So as I understand, one of the key issues is like overdiagnosis, and which was a driving force for the development of risk stratification strategies with which we can reduce the level of overdiagnosis, because active surveillance honestly is not the answer, or not an optimal answer for overdiagnosis. And then how did the new trials implement it? I'm thinking about like MRI or novel biomarkers in the screening pathway.
Well, let me start with saying that I totally agree with you that obviously active surveillance is not the solution for overdiagnosis. We really have to work on overdiagnosis, reduce this as much as possible. And that's what we were looking at. And indeed, the idea of individual risk stratification became obvious when looking at the data of the one-size-fits-all trials like the ERSPC. We immediately learned, also based on long-term data from Sweden, that a baseline PSA was actually very predictive for further development of life-threatening disease. So we use the PSA now as a first risk stratification tool. And that is actually a quite strong risk stratification tool. Because what we see is now if we have men with a very low PSA, we learn from the long-term follow-up of ERSPC that you don't have to screen these men so often, or even, depending on their age, don't screen them at all anymore. And this is a very strong tool. If we look now at PSA cutoff of 3 and higher, we can send almost 87% of men in the age range between 50 and 70 actually back home. And thinking about population-based screening, this is an enormous effective risk stratification step. So some men will never have to come back, others within 4 or 5 years. And this is a huge step forward now in our developments of screening algorithms. So that's the first step. And the second step is obviously now introducing the MRI, which was not available in the beginning. And this has made a big change in actually the detection and the avoidance of low-risk prostate cancer detection. So that is the next step. I only want to add one more thing, because we now know and we learn again from the data from the more contemporary trials like the Göteborg 2 trial, the ProScreen trial, that if you perform MRI directly after an elevated PSA, I think there is a step needed in between. If we look at the data now very carefully, we see that approximately between 30 to 35% of all MRIs that you are doing in such a strategy actually are positive, which means that approximately 60 to 70% of these MRI have a benign result. And in principle should be avoided as much as possible, because it's not only a burden for the patient, but also for the healthcare system and the cost. So with the new contemporary trials, we are learning constantly on how to improve this and working on a risk stratification step before that.
Yes, thank you so much for these really thoughtful comments. So the first step, as I understand, is PSA, remains PSA all the time. And the second step is MRI in case of elevated PSA. So the real question, if we need an additional step between the PSA and the MRI examination, such as the Stockholm 3 or the 4K score or the genetic risk assessment. And it's particularly important from the point of healthcare economics, because if I tell a healthcare economics specialist that I need like 10% of all the screened men should undergo MRI examination, they are not particularly happy about this thing. So it's going to be the question of cost effectiveness, whether these novel biomarkers will be available, wide scale available in every country. So do you have any thoughts on this?
Yes, obviously, this is actually one of the main questions that is currently playing in the field. Obviously, what is the best way to risk stratify men? And then especially in my case, I'm especially interested in a population-based setting, because I want to make very clear that there's a huge difference if you think about your hospital, where men come as in an opportunistic fashion for prostate cancer screening, and you have like the availability of many risk stratification steps, where costs, perhaps, and availability does not play a role. But I'm thinking more in a population-based screening setting, where we're thinking about 10, 100,000 of men that need to be screened. And then the whole ballgame differs suddenly, and their costs and availability and practicality, visibility, everything starts to play an important role. And the thing is, if we look now at the ProScreen trial, where the 4K panel is actually implemented in addition to an elevated PSA, we look at this data, we learn now from those data, and we see that approximately now we see an increase of positive MRIs of approximately 10%. So it's no longer 30% that has a positive MRI, but it is increasing at the cost, obviously, of the 4K panel, and we have to look obviously at the outcome of what kind of cancers are being detected, and this all looks now very promising. So I think similar can be said for the Stockholm tree. What we also have is risk calculators, which in principle are extremely cheap as compared to biomarkers and certainly as compared to genetic testing. So what we actually are lacking, obviously, is a true head-to-head comparison of all these methods and see how it turns out, and also looking at the endpoint, which is very difficult because I frankly think that detecting ISUP2 or Gleason 7 cancers or higher is not the correct endpoint for assessing the value of a prostate cancer screening algorithm. So it will take some more time, and it will take a lot of dedication and the willingness actually to compare things head to head. Then we will learn a lot, and obviously there will never be a one answer to this question. Because if we think about population-based screening, we think about Europe or other parts of the world, there is no one size fits all. Again, there is no one size fits all. It will depend on a lot of things within certain countries, like infrastructure, funding, the healthcare system, cultural acceptance. So, but we are obliged to find out what is the best way. But I strongly believe in risk stratification for sure.
Thank you very much. And considering the not one size fits all kind of approach to prostate cancer screening, as I know, this is something that you are really actively investigating in the RAISE-U project. So can you tell us a few words about the project and the results you have from it so far?
Yes, of course, of course. Well, the PRAISE-U project is a very interesting project in my view. It is different from the ongoing trials like ProScreen, ProBase, Stockholm 3 trials, Göteborg 2 trials. These are all highly controlled, sometimes randomized trials, while PRAISE-U is actually an implementation trial. Due to the changes in the recommendations from the EU, actually the way is now open for member states within the EU to start population-based screening pilots. And they develop these pilots, they are governmental arranged, so they develop these pilots which fits in their local health system. And then men from the population are being invited. There's obviously no randomization, no control arm. It is more about feasibility and acceptance and how does it work within the healthcare system of each of these member states. So in PRAISE-U, we have currently 5 pilot testing sites, 2 in Spain, 1 in Lithuania, 1 in Ireland, and 1 in Poland. And while there is a general basis screening algorithm, including risk stratification, there are, let's say, national adaptations to fit into the healthcare system and to fit into the cultural acceptance of people offering screening programs. So we have different methods of invitations, for instance. In Spain, it is accepted in certain regions that the government approaches you by SMS, for instance, which is, at least in the country where I live, is an unthinkable situation. So there is already something completely different going on. In Ireland, we are going to test home-based PSA testing, which is also different from other screening pilots where the PSA, the blood drawing, is done in a screening facility. And in Ireland, we will do it at home. It will be interesting to look at compliance and response rate, and obviously also further down the line whether men will actually come for a further assessment. In Poland, we have a very rural area with a lot of people with low income, and we are very curious how it will work if men have to travel quite far to a screening facility to participate. So these are all kinds of concerns, and we will learn a lot from how the data from these highly controlled randomized trials fits into the real world and see how they turn out when you actually start to implement all our knowledge in the real world. So that is PraisU all about. And we are currently working with the pilots. They are started last summer, so we are halfway now on getting data of these pilot studies.
So thank you. This sounds really exciting. A key question in screening trials is the participation rate. Despite the high-tech techniques that we have, novel biomarkers and MRI examinations, participation rate is a key component of every screening trials. And as far as I know, it was not so high even the trials. So how can we address this challenge in the real-world setting?
Yes, this is certainly a point of concern, and this is not only currently the fact for prostate cancer and these pilots studies, but it is actually something that we see overall with cancer screening programs, that there is a decline in participation actually continuing after COVID. So it didn't come back to the original level. So we see a decline. If we look at the Netherlands, we see a decline in the participation of the breast cancer screening, the colorectal cancer screening, and the cervical cancer screening. That particularly is going to be is very low. And these are now percentages of compliance that drop down, let's say the magical percentage of 70%, where according to the WHO, you need to have at least something like 70% compliance in a population-based program to be effective. And we are currently seeing some data that it is going to drop near that level of 70%. If we look at prostate cancer screening, this is a major challenge. Even in the randomized controlled trials, we never achieved 70%. And currently in the OPT program in Sweden, albeit that there are mostly younger men now being invited, which is always a little bit more difficult to get them to attend to a cancer screening program, but they are also not in the range of the 70%. So indeed, we have to work very hard on looking what the actual reasons are for this compliance issue and work on different methods of certainly of awareness, because I think a lot of still is due to a lack of awareness and people are not familiar with the idea, certainly men, that they have to go for prostate cancer screening. And then obviously on the methods of invitation, because I am a truly believer in a population-based approach instead of a opportunistic testing approach, since by opportunistic testing you will only get those men that are really healthy aware, and what we actually would like to have is those that are at high risk, and those are often not the most healthy aware men. So I truly believe in a well-functioning population-based approach, but I do admit that it's a huge challenge to achieve that.
Thank you so much. So based on this, the importance of soft skills, communication, and marketing of screening cannot be and should not be underestimated.
No, certainly not. No, this is crucial. This is crucial. It is not like perhaps most people think you just send a letter and the men will come. This is not how it works. There needs to be a lot of good communication, instructive videos, perhaps even meetings at local facilities to get men more informed. So a lot of this is being tested also in PraisU to see what actually affects compliance to this prostate cancer screening programs. And I'm very looking forward to see more data on that, because I think this is one of the most important issues within prostate cancer screening.
And how is it with other type of cancers which can affect both male and female patients? Like, for example, colorectal cancer screening in the Netherlands, which can be done at home with a home kit. Is there any difference between the participation rates of the two genders?
The thing is that the participation rate, at least in the Netherlands for colorectal cancer, is currently around this 70%. And there's actually not so much difference between men and female with respect to compliance. So that is very interesting to learn about. Perhaps it is when you are living with your man or as a couple, perhaps it helps to participate. I don't know exactly what the reason is, but certainly the home-based testing will help enormously in this case, I'm sure. And I know that there are also thoughts about combining, for instance, prostate cancer screening with breast cancer screening, to get the compliance level up. So I think that's perhaps also a good idea. We can learn from that, from the colorectal, perhaps, indeed. So it is a challenge. So also in colorectal cancer, in breast cancer, and I think working together, learning from each other will certainly help to increase our participation rates, for sure.
So we arrived to a really interesting point in the talk. I would like to ask you about the role of DRE in contemporary prostate cancer screening pathways. As I know, in 2024, there were several papers published in, for example, one in European Urology Oncology from Akihiro Matsukawa, and they showed that DRE is not an effective tool in prostate cancer screening. Would you share your thoughts about this issue with us?
Yes, of course. In principle, I do agree with that conclusion, because I think DRE as a first-line screening test is obviously not a perfect test. We should never do that. But maybe after a risk stratification step or after MRI, in men considered really to be at higher risk of having a clinically significant prostate cancer, I would not immediately say don't ever do it. And I would like to show you a little numerical example about this, because people don't really realize how many men are actually involved. And if we invite, or if we see 10,000 men and they are screened for prostate cancer, 10,000 men in the age of 50 to 70. If we then look at the men that have a PSA of 3 or higher, it's about 1,250. So there you again see the enormous strength of a PSA risk stratification step. Of these 1,250 men, if we do an additional risk stratification step, whether that is Stockholm 3-4K, a risk calculator, PSA density, which is certainly a strong risk stratification method, we see that approximately 30 to 50% of the men drop out. They are not considered at high risk. So we have, and again, think out the 10,000 men we started with, we come up with 625 men for an MRI test. If we then have approximately 40% who have a PIRATES 3 to 5, we get 250 men, and that is 2.5% of our 10,000 men, that are being referred for further assessment, and that being a prostate biopsy targeted. And actually, if it helps, because then obviously the urologist comes into place, if it helps them to further assess the real risk, or to think already about the T stage and the further potential treatment options, I don't see so much harm in perhaps including a DRE at that point in time, but certainly not in the 10,000 men you are going to invite for prostate cancer screening. Certainly not.
These are tremendous numbers, and I was thinking that the advance that we have made since the first trials that we started our talk with, it's just really, really tremendous too. And you mentioned urologists in the screening pathway. I'm really curious, what do you think that where do the urologists come into the game in these screening pathways? After the PSA, after the MRI, before the biopsy, where is the role of the urologist in the contemporary screening pathway?
Let me first again stress the difference between a population-based screening program, which is initiated by, let's say, the government, and of course opportunistic testing, which is a totally different pathway. In the first case, I would say the urologist comes into the picture after the diagnosis has been made. Because the first thing is screening, and screening is something that needs to be done according to a certain algorithm. And I think it is best executed in a screening facility where the screening is done. And in fact, after the final step of the screening, and there's the unfortunate event that a man is being diagnosed with prostate cancer, then for sure, obviously, he needs to see a urologist and think about the further steps that are necessary. I know now in practice that this is not the case because we really lack of organized prostate cancer screening programs. There's only one country currently, that is Lithuania, and of course the OPT. But there, the last stop is still done within the hospitals, which is fine for now. But if you ask my honest opinion, how do I think that cancer screening should be executed? And I think that should be done outside clinical care in dedicated screening facilities. And you enter the clinical pathway as soon as you become a patient. And that's how it should be done.
So as the final step, you mean final step after the biopsy?
Yeah, well, with the biopsy, but I don't know whether the healthcare system of the certain country can actually accommodate that. So when all the men, let's say that you start a national population-based screening program where all men living in your country will receive an invitation, and let's suppose that the compliance is up to the certain level that we want, I'm not sure whether the healthcare system can accommodate everything. I think that the government needs to assure that there are screening facilities where this can be accommodated, all these biopsies, all these MRIs. And as soon as you become a patient, obviously the whole world changes and you need a urologist to help you further.
Well, this is something dramatically different than opportunistic pathways that we have now. Like, I think as a urologist, we all know the colleagues that and the patients who come at the age of 65 with a PSA of 0.4 every year for their regular PSA testing. They insist on the test until the age of 80. Yeah, this is dramatically different. But this indicates the different perspectives which we have in the clinics and which are implemented in the public health systems and public health stakeholders. So it's a completely different point of view.
It is, and I think the switch from one to another view is certainly not easy and will take many, many years if it will happen ever, because that I don't know, obviously, because we are learning constantly also from these pilots, from PraisU, and from the other initiative, the joint action from all the EU member states on cancer screening, where in EU Can Screen, as it is called, also a particular task is completely dedicated to prostate cancer screening, and many more member states are initiating pilots for prostate cancer screening. And in the end, we will learn a lot from this, and whether not only about the algorithm itself and the effectiveness of the algorithm, but also how it fits into current clinical care. And I'm really looking forward to the coming years to learn a lot about it. And there's currently no best way. It is there are two things existing in countries that have pilots, and that is the opportunistic testing within clinical care and these national initiated screening pilots. And we have to learn from each other and see how they might mix or how they might, or one might replace the other. And that will again be different in each member state in Europe.
We have started with the history of prostate cancer. Then we talked about the current treatment strategies, the current pitfalls and challenges that we have to tackle in the future. And finally, we arrived at the future. What do you expect prostate cancer screening will look like in 2030 or 2035?
Well, expect, but I really hope that there is some kind of program within Europe, and that we have diminished as much as reasonably possible the opportunistic testing, which in general does more harm than it does good. So that's what I hope. And I also hope that science will bring us to an algorithm which is as objective as reasonably possible. And that with that I mean that a PSA test is an objective test. It is not judged by a human, it's a machine. It is calibrated, it is constant, and it's cheap, so that is already there. But hopefully we can also find something for risk stratification and for MRI reading. For me, working on population-based screening, I think it is crucial that if you as a man attend a screening program, and let's say within your country, and whether you do that in the very northern part of your country or the very, very southern part of your country, the results should be the same. It should not be dependent on a very high qualified radiologist working in the north, and in the south you get a totally different result. That is something that we need to eliminate if we talk about population-based screening programs. So I sincerely hope that with all the ongoing research, we in the end come up with a national organized population-based screening program detecting those men that really need early detection and treatment by an objective screening algorithm.
Thank you so much. I can't resist asking one more question, because you were talking about that the quality of the interpretation of the MRI should be the same everywhere. Do you think AI will bring a solution to this challenge?
I hope so. I sincerely hope so, because it's not only the MRI, we also have to think about judging the biopsies. It's also a very subjective part of the diagnostic pathway, right? You're depending on a pathologist's view. And there also MRI is already working and taking over some of the work. And I sincerely hope that we can eliminate as much as possible the subjectivity of these steps within the screening pathway.
Professor Roobol, thank you very much for these really valuable and insightful thoughts that you shared with us today.
Thank you. Thank you very much for the questions. Thank you.
And this was today's AU podcast on the challenges and opportunities in screening for prostate cancer. We hope you enjoyed the talk and hope to see you next time.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on urological advancements, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.